Well, we begin. As the last session ends late, we will take only 33 or 35 minutes to end this session. First of all, I would like to express my congratulations to the organizers for inviting me to moderate this panel. And I would like to welcome our panelists, Dr. Toumbis, Dr. Kourea, and Dr. Ouali from Tunisia. Dr. Toumbis is from
Cyprus, Greece. I'm from two countries.
and Dr. Kourea from...
Yes, I'm from Greece, Athens, Greece.
From Greece. Well, welcome,
Thank you.
dear assistants. I'm Dr. Mili. I'm pulmonologist and addictologist, and I'm certified tobacco treatment specialist from the Mayo Clinic and from the American Professional Addictologists. I'm the chairman of the Tunisian Society of Tobaccology and Addictive Behaviors. It's an honor for me to moderate this session and this panel about best practice in smoking cessation. Smoking is addictive behavior, and without assistance, it's very hard to break the habit. And most of quitters relapse within days, weeks, or months. They may face hard urge to smoke and face big difficulties to manage their mood. Sharing our experiences from experts is very informative. In this first time, I will ask our panelists to present their experiences from their clinics and their experience about smoking cessations. And the second part, we will focus on specific questions. We begin with Dr. Kourea.
Yes.
Will you do present yourself
Yes.
and present your experience about your clinic cessation?
Thank you. I'm a cardiologist. I'm working in a university clinic as a cardiologist in Attikon Hospital here in Greece. So we see a lot of patients after a myocardial infarction or people with a lot of cardiovascular problems that are smoking. So it was a necessity for us to start dealing with smoking cessation. That's why we started this clinic, and that's why we are continuing to evaluate all the patients and do a lot of clinical work on smoking cessation and cardiovascular disease. In our clinic, there are two parts. The one part is the part of the clinical work. We are going to all the patients after myocardial infarction, so we can give them a consultation and also give them the right medication in order to stop smoking after their discharge. And we also have an open day clinic, so people that can come and visit our smoking cessation program. That's the way we are working. We also have other people working with us. It's Professor Konomidis who is in charge of this center. We also have a psychologist, a dietitian, and people working in our research group.
And can you tell us more about your successful smoking rate? If any.
For us, it is very interesting what happens to people after an acute attack, an acute heart attack. That's the target group of the people we see. And we just published a paper and that we saw that people, when they get discharged after the infection, they all say, I'm not ever going to smoke again. But when we called them in 3 months, half of them were smoking either systematically or periodically, and in 6 months, nearly 85% of these patients were regular smokers. That's the big problem for us cardiologists, the relapse to smoking. And that's something that we're trying to address.
Yes, it's equally the same rate between all cardiologists, the 15% of relapse after 6 months
Yes.
of the acute attack is usual, and it's a big problem, yes, for patients. Thank you, Dr. Kourea. Dr. Toumbis, what about you?
I'm a pneumologist, not cardiologist. So the first is we have a consultation about the chest diseases. And second, we pay attention to the addiction. We have very effective medications for the first phase of our approach for 2-3 months, but then we have the lapses and relapses, and at the end of the year we have about 60 to 70% of relapses. So we pay attention to this parameter because we believe that the not medication approach, it is not very high in our society and our clinic. In our clinic, we have a psychologist, an immunologist, nurse, etc. The role of the nurse is to keep in contact with the smokers every 15 days. She makes calls to the smokers and asks if there are any problems. And if there are any relapses or lapses, then we call the patient to come back and discuss about their problems. We have a behavioral approach. We have, in order to increase our success about the smoking cessation, and we educated the patient to the so-called besides the behavior we have there, anyway, we educated the patient to the smoker in several skills in order to manage the lapses first of all, because the first step is the lapses. And we ask the patient to recognize the risk factors for the lapses, and we discuss these risk factors, and we try to help him to manage these risk factors. Through this policy, we have fewer lapses and more success at the end according to the relapses. We believe that the key point is the behavior. It's the behavior of the smoker, because nicotine withdrawal symptoms are managed with the medications, but the behavior is there, and the behavior is going to keep the smoker alarmed. Is a behavior that is going to become a relapse.
Thank you, Dr. Toumbis. It's very informative. Then we go forward about the specific questions. First of all, about pharmacotherapy, and I would like to ask you, Dr. Toumbis, what about the strategies about replacement nicotine therapy we use to advise long-acting nicotine therapy replacement and a short-acting therapy replacement to make smokers the capacity capability to face the urge to smoke. What kind of short-acting you advise? Have you preference for gums, for lozenges, tablets, or for nicotine inhaler?
Yeah. First of all, we separate all the medications in two categories: the reliever and the controller. The reliever, belongs to it is included the nicotine replacement therapy. And for the management of lapses, we prefer to suggest the use of inhaler or a spray, yes, and finally a pastille. But it's according to the patient, because if the patient has a problem with his teeth, then we prefer to give him sprays, nasal spray or oral spray. And but this category is using for relief, for the lapse. And if we can manage the lapse, we then introduce and one of other category, such as Toumbis, varenicline.
Varenicline is not available since 1 year now. Do you?
It's a big
have
problem.
It? And if no,
during the last 3 months, we have a problem.
We have a problem.
Because it is out of a market, the varenicline. And but we have the bupropion.
Have you an experience with the Citizen?
Citizen is not available.
It is not available.
It's not available.
Yes, in Europe.
It's only in Western Europe.
Western Europe.
Yes, but unfortunately, it's a very good medication, but we don't have it.
Okay, thank you, Dr. Toumbis. Alors, another question for Dr. Kourea. What place do you reserve for RRPs, reduced risk products? Do they advise them in the beginning of the prise en charge, or you let them at the end, as Dr. Toumbis said to me? Enough.
Excuse me, I didn't understand the question. Can you?
I told him that I don't give the novel products in smoking cessation. I keep them at the end, but unofficially.
Yes. It's a big question, because all the patients, it's the first question. What can I smoke besides normal combustible cigarette? Our opinion is that you can't give them such a choice by the beginning. You should advise that there are medications and that you should completely quit nicotine in any form. That's the only thing that can keep them a long-term smoke-free. That's the doctor's way. But unfortunately, that's something that a lot of times it isn't working as we want. So we have to explain what's harm reduction to the patients. I also wanted to say that in our clinic, we are using combination NRT, something like a long-acting agent with a short-acting agent, like a patch with a gum, and we gradually lower the nicotine level in order to keep the patients smoke-free.
Okay, thank you. You know, the approach, I think the approach is a bit different between practitioners, certified tobacco treatment specialists, and addictologists.
Yes.
The addictologist approach is very different, in fact. We do not advise, we prospect. Prospect difficulties. Smokers, as all addicted, are facing too. And we try to engage them in a kind of self-confidence that could engage themselves in quitting. You know, it's this feeling, if they feel they have capability, and they are able to change behavior, and they have self-confidence, sufficient self-confidence, they will engage in this behavior, and because of that, they must be given possibility to choose what kind of aid they want to keep with them. If they have preference for RRPs, for e-cigarette, for heated tobacco, why not? Our role is to inform them about the risk. And we try to inform them about in which risk they want to keep themselves. Without risk, with pharmacotherapies, with a little risk with e-cigarette, and with just that bit other risk with tobacco, with heated tobacco. But the main target is zero smoke. You know,
Yeah.
This is the approach. I think the experience we have with our smokers and even with heavy smokers and other addicts, the smokers have a big chance to have RRPs and nicotine-reduced risk products, because in the other hand, with other addicts, we have nothing except with the opioids users, with methadone, for example. Then it is very important to use these tools and these means to make smokers have more
More chances.
more self-confidence to engage in this behavior. Because when manage smoking cessation, we have pharmacotherapy, we have CBT. CBT include motivation and interviewing, and coping skills. Coping skills, it's not enough for relapse prevention. When we want to engage in change behavior, we must have motivation, high motivation, and a high self-confidence to engage in this new behavior. That's why we are working hardly with smokers on self-confidence. Because
Yes,
self-confidence engage negative emotional state and negative affect. How to manage negative affect? We cannot manage them with pharmacotherapy, but we can manage them with CBT and with cognitive therapies.
According to Kourea, the behaviorist approach is not effective in the prevention of relapse. And I don't understand why. because I believe that this is the method that we can stop the relapse. We should keep attention on this type of approach to change the behavior of the patient.
Yes, absolutely, absolutely. Because changing the behavior is a learning, is a new learning. And smokers, as all addicts, have to learn how to manage their lives, how to manage their mood, how to manage their negative affect. How to change their modalities to manage their lives. Maybe it takes years, maybe it takes months. During all this period, they must have something to deal with.
Mm-hmm.
Yes.
Pharmacotherapy, another thing. Et puis, the preferences of smokers, in my point of view, is a very important point to specify.
Yes, and it's also very interesting that we deal with people that are hospitalized, and we see every day that it's not the reason that they have a problem of health, a serious problem of health, that they quit smoking. It's something much more personal.
Yeah.
It's a motive that it's not even recognizable to us. It's only to them. And that's your work to do, to deal with.
And you're a psychologist.
No, I'm a psychologist.
Thank you very much, our panelists. Any question in the assistance? Yes.
What do you think about the shocking advertising? I'm interventional cardiologist. Just a moment. I'm an interventional cardiologist. I treat myocardial infarction or acute coronary syndrome, and I use the shocking advertising for our patient. What do you think about this method in psychology? Because the patient in this moment can accept all advertising, all message. He can see the arteries, the injury into the arteries, the stent numbers. My second question is for Dr. Kourea. What do you think about the passive smoking when you see women's for acute coronary syndrome or other member of the family?
Okay. I can answer the second question. We see usually when we take the smoking status of the patient, we ask about the family. It's very important because we saw by studying all these patients that when we have a family that everybody's smoking besides the smoker with the infarct, it's a kind of serious problem that we will have a relapse in some months. And for us, it's very important to work with these patients because as cardiologists, we don't have a lot of time to deal with smoking cessation and nicotine dependence. If you take the time to express, to say to the patient how it's working and how important it is to not even have a puff for a lot of months afterwards, maybe you can convince a patient to not start smoking again. Because as you know, when you are close to the event, you are very afraid that something bad is going to happen to you, and you don't do it. But 6 months after that, when you are with your friends or your family, when they offer you a smoke, it's very important to say no. That's the main focus that we have when we consult patients in the clinic. About passive smoking, you know that passive smoking is a strong risk factor for cardiovascular disease and for pulmonological disease. It is something that increases at about 25% the incidence of cardiovascular and pulmonological events. So we also have to work with the families in order to eliminate passive smoking and elevate the success rates of our consultation.
So the last question?
Yes, thank you. Well, making smokers with smoking-related complications like cardiovascular disease and cancer and neurologic problems quit, it sounds complicated already, but actually managing these patients in real life, in the clinics, we all realize that it's even 5 to 10 times even more complicated. Obviously, what is very remarkable is the cognitive dissonance in these patients. All of them realize it's bad for them. All of them desire to quit smoking, but they simply can't. There's a dissonance. Their cognition does not seem to be synchronized with their will to effect that change to quit smoking. And that is the reason why I believe that there's a big gap that has to be filled, that is pharmacotherapy. Pharmacotherapy not in the terms of nicotine replacement therapy, but the use of drugs like varenicline, ibuprofen. Unfortunately, sometimes the treatment is worse than the disease itself, the side effects due to this drug. So I think if we can come up with newer drugs or repurposed drugs, which use in psychiatry, which could really control the craving without the side effects, which varenicline and ibuprofen may cause. I think that can fill in the gap, because we've always proposed that it has to be a multi-pronged approach. Not a single, simplistic, monotheistic approach, but a multi-pronged approach. And I think pharmacotherapy plays also an important role.
Yes, maybe with transcranial stimulation, maybe we can reach what you need, and we can focus on certain areas in the brain that are involved in addiction and in craving,
Yes.
and stimulating them with this new therapy, transcranial stimulating therapy, and we have good feedback with addictions and not yet with smoking, but with addictions, substance use disorder. We have good feedback.
Yes, precisely. May I just quickly add that, I believe in cognitive behavioral therapy. It works. But the thing is, it takes time. It takes time to work. So we need something to really jumpstart the process. And I think that's where pharmacotherapy works, and the long-term sustenance can be taken care of with the cognitive behavioral therapy.
But in all circumstances, smokers, as all addictives, must learn how to manage their lives without smoke.
Absolutely.
Thank you.
Just have one comment. If one has high blood pressure or diabetes, takes medication for a life. For smoking, we have 3 months medication, 3 months approach. It is unrealistic. So we have to prolong our approach to the smoker in order to have successful results.
We have a new approach with the pharmacotherapy. Now we
6
can
months.
put them and advise them for 1 year, for 2 years, and even for lives. Even for lives, for long life time. It's the same because we agree that smoking is a chronic relapsing disease, and we must cope with it as with all other chronic diseases. Thank you, our panelists. Thank you, our assistants.
Thank you very much.
Thank you very much.